Hi, this is Fumi with Rotate Ready. I'm a clinical pharmacist by training, and my practice setting is an AmCare setting, and I work in the adult and family medicine department. So this video, I'm going to be showing you how to calculate the initial dose of insulin in an insulin-naive type 2 diabetic patient, and also kind of, walk you through which one to start or how to start. So basically, if you have the question of do I start with long, short, or intermediate acting insulin, well, this is the video for you. So when might you consider adding on insulin to a patient's regimen in an insulin-naive type 2 diabetic patient? Well, according to the 2019 ADA guidelines, you really should consider dual therapy when a patient's A1C is greater than or equal to 9%. So by dual therapy, I mean they're already on oral therapy and their A1C is still not controlled, and so you're thinking of adding on insulin at that time. However, when their A1C is greater than or equal to 10%, you definitely want to really consider combination injectable therapy at that point in time. So then which one may you start with? Well, again, according to the guidelines, you really should be starting with basal insulin. Oftentimes, I've seen in practice where prescribers may start off with mealtime insulin, and it's not recommended to start with mealtime insulin. You really want to start with basal insulin. It's the most convenient for patients because the dosing usually is once or twice daily. So what dose might you start with? Well, usually you want to start with at least 10 units a day, and sometimes depending on the patient's preference, I will either do it in the morning or in the evening, but you could start with 10 units a day. But the more accurate dosing is the weight-based dosing. So it's more, maybe not more accurate, but more individualized to the patient. And so it's usually 0.1 to 0.2 units per kilo per day. Okay. And so I'm going to calculate using an example with a 100-pound patient. Say our patient weighs 100 pounds, excuse my zero here, and we want to calculate how much insulin they should be getting. Well, you want to convert this to kilograms because that's what this unit calls for. So there are 2.2 pounds in 1 kilogram. Okay. So in order to set that up so that you're able to get your desired weight, you want to have what you desire. So the desired unit is kilograms. So I'm setting that up to have that on top. 1 kilogram in 2.2 pounds multiplied by 100 pounds. So this crosses out. 1 times 100 is 100, of course. And then that's divided by 2.2. So I know this is probably going to be close to or slightly less than 50, but just because I want to be as accurate as possible, I'm going to go ahead and use my calculator here. So 100 divided by 2.2. So it's about 45 pounds. So 45 kilograms, not pounds, 45 kilograms. So now we have the patient's weight in kilograms. Now we're going to calculate our dose. So say we wanted to use the lower end here. So 0.1 units in 1 kilogram. Okay, so 0.1 units per day in 1 kilogram. Times 45 kilograms. This crosses out. And then you multiply 45 by 0.1. So that gives you 4.5 units. And so that's 4.5 units per day. Now you could approximate this to be about 5 units. And you could start off with maybe 5 units at night. If you're using Lantus, you could start off there and then titrate upwards based on blood sugar response. So that's how you would calculate this. If you're using Humulin N, the dose is so small that you don't necessarily need to split that, but generally that's more of a BID dosing. So you could start off here and then titrate upwards based on blood sugar response. So in terms of which type of basal insulin to start, that's really based on the patient variables and some age-related variables. So you might want to consider things like cost. What can the patient's insurance afford? What can the patient afford based on their insurance? You may want to look at the pharmacokinetic profile of the type of insulin and kind of tailor that to the patient. So for instance, I may consider using a long-acting peakless insulin such as Lantus. The onset is about 3 to 4 hours. Again, it's peakless, and I might consider that in a patient that I know is prone to having hypoglycemia. Because overall there's less incidence or less of a risk of having hypoglycemia with Lantus than with, say, intermediate acting insulin such as Humulin N. Another consideration may be if sometimes I have patients who just don't eat regularly, say their work schedule just doesn't allow for it. I'm usually hesitant to use basal insulin such as Humulin N because of the peaks, and I want to try to prevent hypoglycemia as much as I can. So again, I might consider Lantus in that patient. But other than that, there's really nothing wrong. You can go ahead and use Humulin N. You can start with once daily dosing, or you can do BID dosing. Just know that if you do once daily dosing, each dose of Humulin N lasts about 12 hours. So you're really not having that 24-hour coverage that you may want or desire from something like Lantus or Levemir. But it does offer that flexibility and cost. It tends to be a bit more cost effective for patients, depending on which insurance carriers they have. You may also consider using other types of basal insulin like U300, Glargine. You may consider Degludec. These confer a lower risk of nocturnal hypoglycemia. So if a patient, say, had that issue, you could consider that. But again, cost may be an issue with Degludec, so you want to be aware of that. Now, once you've chosen your basal insulin, then what do you do next? What happens? Say the patient is still not controlled, and what do you do? That's the time you want to consider adding prandial insulin. That's when you want to consider combination injectable therapy. So you may want to start with, and there are different types of prandial insulins, as Lispro, Aspart, several types. So say we were going to go with Humalog. Sometimes I'll tell patients to go ahead and start 4 units of Humalog with before the largest meal of the day. And then you can assess, once or twice a week to see what their blood sugar control is. And depending on, how well controlled they are or not controlled they are, you can choose to add on, more prandial dosing up to 3 times daily before each meal. So, it just depends on what the patient's blood sugar control is. I do want to say you never want to start with rapid acting insulin as the initial glucose strategy for an insulin naive patient. For one, they're insulin naive, and depending on how frequently you might prescribe that, it may not be convenient for patients. If you say you start off doing 3 times daily, that may lead to non-adherence. And also that strategy is just not recommended by the guidelines. So you want to try to make sure you start off with basal and not prandial. So that's it. I hope that this was a good overview or review for you, and I hope you find them helpful. As always, remember to keep your head up. You got this. You can do it.